So today we're going to be talking about juxtaposed homonymous hemianopsias. And an easy homonymous hemianopsia is one that's either on the right or the left side. And as you know, we project the field as if the patient is looking at their own field. So in this example, the shaded portion represents the right homonymous hemianopsia. And so that's usually an easy field to diagnose. You know that the lesion is behind the chiasm because it's a homonymous hemianopsia. You know the lesion is on the contralateral side from the homonymous field defect. What's harder is when you have two homonymous hemianopsias juxtaposed together. And that occurs when you have a bilateral lesion, for example, a bilateral occipital infarction, or you have prior temporal lobe infarct and now you have a new occipital lobe infarct. That combination will produce a juxtaposed homonymous hemianopsia. And so one of the easiest ones is when one field is a right denser inferiorly homonymous quadrantenopsia, and the other side is a juxtaposed left superior quadrantenopsia. And as you can see, this generates kind of like a checkerboard pattern, like the BMW logo. And this right here happens to be an example of one of these checkerboard fields where you have a right denser superiorly homonymous quadrantenopsia juxtaposed to a left inferior denser inferiorly quadrantenopsia. And so it generates this kind of a checkerboard field. The one that's harder is if it's not a checkerboard and if you have something that looks like this. So you have a left homonymous hemianopsia juxtaposed to a right homonymous hemianopsia, but they're both superior. And if they're both superior, it's going to look like an altitudinal field defect bilaterally to you. So normally altitudinal field defects occur from nerve fiber layer loss from disease in the eye. For example, a branch retinal artery occlusion or old ischemic optic neuropathy, or something that's damaging the nerve fiber layer from below. And in a juxtaposed homonymous hemianopsia, the tip-offs are going to be, number one, the acuity is going to be normal because they can still see 20/20 with this bottom part of the macula. Of course, the pupils in retrochiasmal disease involving the occipital cortex, for example, are not going to have any pupil abnormality. The rest of these structural eye exams are going to be normal, and the disc is going to be normal. So in a bilateral occipital infarction that is affecting the inferior calcarine cortex bilaterally, you'll get juxtaposed homonymous hemianopsias that will look like a bilateral altitudinal field defect. And the same defect can occur inferiorly, of course, where you have a left inferior quadrantenopsia juxtaposed to a right inferior homonymous quadrantenopsia, and again you'll get the altitudinal character. So one of the things that can help differentiate these juxtaposed homonymous hemianopsia is the presence of macular sparing. And so if we spare the macula in a homonymous hemianopsia, and even if you juxtapose another homonymous hemianopsia onto that, you'll still have preservation of the vertical step, and the presence of that macular sparing will help us to differentiate that this is actually two homonymous hemianopsias juxtaposed together. One is more complete than the other, one is denser superiorly, but this kind of visual field is also juxtaposed homonymous hemianopsias. So the major teaching point is if you have 20/20 acuity, a normal pupil exam, and a normal fundus, and the rest of the structural eye exam is normal, and you see a field defect that's on both sides of the vertical meridian, the key feature is looking for that vertical step. If it's a checkerboard, that's pretty easy. If it's altitudinal, we're going to want to cover one side so we can uncover the homonymous nature of this field, and we're going to be looking for either the sparing of the macula or respect to the vertical meridian in the remainder of the field so that we don't think this is an arcuate scotoma from glaucoma or some other optic neuropathy fields when you're really dealing with juxtaposed homonymous hemianopsias.